Well, welcome everyone again to another VITA learning webinar. Today we have Mr. Mark Wagenseal, a denturist from Alberta, Canada, that is graciously going to go over what could be to some maybe an unknown, complicated or not complicated. You know, how to deal with not the normal bite relationship. He's gonna go over the class 3 bilateral crossbite end-to-end type scenarios on occlusal scheme. How do you handle it? How do you communicate it? How does it work? How does it function? What the boundaries are, things of that nature. So welcome, Mark.
Hello.
Mark, is everything going well up in Canada?
It is. We're still here.
Excellent. So we love Mark joining us on these webinars because he does a very interactive program. He's not just a denturist technician. You know, he also he loves educating. So he is going to educate you today on how to deal with these special type cases. And make sure though that if you do have any questions as you go through, that you go ahead and type those in. So those of you that have that are online, when you went to the GoToWebinar, a panel on the right hand side, if you're not familiar with it, popped up. There is a question box that if you open that up, you would be able to type in your question. And then at the end of the program, we will have a Q&A. So right now, everyone is on mute. They're in listen mode only. Questions will be held at the end of the program. The webinar is recorded, so you can visit today's webinar with Mark or past webinars that we've recorded with Mark, dealing with all sorts of different, you know, class 1 and class 2, class 3 type occlusal schemes, different configurations. We've got a lot more on the way the rest of this year, then we have some again next year. So these seem to be very popular, and Mark's a great educator. As I mentioned, he loves to teach, not just show his work, but actually teach someone how to do and how to think of things that need to be done so that you have the best benefit for that patient. So with Mark, Mark is a global certified trainer and management consultant. Mark is a licensed denturist and dental technician with over 30 years of experience. He owns the Heritage Denture Center, a dental lab in Edmonton, Alberta, Canada. He's spent his career focusing on how dentures integrate in the mouth and body, and inspires a unique awareness of occlusion and professional growth, which is very true. And we really appreciate that, Mark, how you teach all of us. And we know that, you know, learning never ends. And with someone like your capability and your experience, you certainly provide us with some insight, especially since you're a denturist. As a denturist down in the U.S., we have more technicians that do denture work, and they very rarely see their work in the intraoral environment. And that's a tough one for us sometimes when we don't see exactly how it fits in the try-in and so forth, and then we wonder why we have to reset bites and things like that. So without further ado, I will turn this over to Mark. And again, thank you, Mark, for participating in this VITA Learning webinar. And I will now make you the presenter.
Yes.
And we should now see your computer. It's coming on board. Excellent.
Okay. Hi. Okay,
All right.
can you see that, Jim? So
all right, we can see that. You're up and running.
All right, I might check in with you every once in a while just to make sure you can see stuff.
You got it.
And can you see me, or is it just the PowerPoint?
I can see you, as well as see the PowerPoint. Yes.
Okay, awesome. Thanks, Jim. Good morning, everybody. Thanks for making time for me. Whoop, whoop. Happy day. Hope you're all doing well. Thank you for taking a moment out of your busy schedules to come join us and to invest in yourself. This is about you being a superhero. This is about you being a superhero to your patient or to your doctor and your doctor's patient. Somebody along the way is a patient and is trusting one of us to help them and to help them eat and have a life. You have to remember, you chew and you eat 3 meals a day, sometimes more. Chewing and eating is a big part. And anyone that's ever had restrictions on food or restrictions on eating realizes how much it impacts your life. And we're here to be superheroes for people, and superheroes that are trusting us to help them have a quality of life and chewing life. So thank you for joining me. Thank you for investing in yourself. I really appreciate it. So this is about us supporting each other and our journey. So let's get started. So crossbite is complex treatment care. It's not regularly taught in schools. You'll learn it on the school of hard knocks, as they say out in industry, and it can be very challenging. And so I want to share with you some common issues and some solutions to take with you on your journey. So what are our common issues? Well, denture teeth chip, break, and pop off, and patient can't chew well with the denture. They come back and they just say it's not working. And when you ask them, they just say, well, it just doesn't work. I just can't. You have to keep in mind, what are the denture teeth designed to do, or what are teeth designed to do? They're there to bite off food. They're there to mince the food and grind it into a ball called a bolus. Stick it together with saliva so it forms a ball, so you can swallow that ball, and your esophagus squishes the ball down into your stomach. Your stomach then is moving and breaks apart the bolus or the ball of food and blends it with acids that dissolve it and then pass it into the intestines to be dissolved and absorbed into your system. If you can't chew your food well enough, you can't mix it into a ball well enough. You can't swallow that ball properly and bits break off, and you have a swallowing hazard or a choking hazard, pardon me. Then you're sending down too big pieces of food into your stomach. It can't absorb, it can't break down, and the acids can't break it down quick enough before it gets passed along into your intestines that can't absorb it. And from there, it gets passed into your colon. It's very interesting. I want to bring this up. Through my journey, I have started asking patients, I'd like to talk to you about your bathroom habits. And are you on a laxative? Are you plugged up? Can you go to the bathroom? When we go to the bathroom, our poop needs to be in the shape of a hot dog and soft. That tells you that the system is working properly. And if that's not the case, if there's other medical issues going on, we can trace some problems back to chewing, and that we're not chewing the food properly and mincing it properly for the system to work. And it gets misdiagnosed often by doctors and the medical industry that we have a chewing issue. And when I bring it up to doctors, especially doctors that I just meet along the way, they don't usually stop to say, hey, wait a minute, that's a good point. Your teeth have to work for everything else to work. And that's really important. And it's interesting because now when I start to ask patients that, you'd be surprised how many patients we can get off a laxative. Number one, how many are on laxatives, and now we can get them off because we've increased their chewing. So that comes to our common issue of not chewing well with a new denture. We want to make it more efficient. New dentures are looser than the old one. That's also common with crossbite. And multiple relines with no success. Of course, breakage, food collects under the denture, but you don't need to reline it. That's common for us as well. We don't need to reline it because it fits against the gum. So when we check it and the doctor checks it, it fits against the ridge. Yet it's always loose and the patient's complaining. So then they use an adhesive. It's loose because it's getting knocked around when they chew. Denture feels too big, and then of course sores. temporary denture preferred over a permanent, even in crossbite. So these are some of our common issues, and these issues cause us stress. I want you to appreciate you deal with those stresses every day in your jobs and in your professions. And you have to keep in mind over a period of time, it slowly builds up. So you deal with these stresses, and it's day after day after day of similar or common problems, and it wears you down after a while and through your career. This is something that I've noticed now through speaking with other professionals as I lecture globally, that these stresses are real, and they're they're real, and they impact you and your health. It's compounded now with a class 3 jaw relationship. So crossbite, by definition, is a form of malocclusion where the tooth is either more buccal or lingual in position. We call it malocclusion in dentistry. So either the tooth's too close to the cheek or tongue, then its corresponding antagonist. So again, we call it a malocclusion. So in other words, it's a lateral misalignment of the dental arches. However it got there, however it developed, it's there. It's interesting because nature finds a way. So we have someone with crossbite, and I want to take a moment to just acknowledge Lady Gaga and her song, Baby You Were Born This Way. Look, this is how we find it in nature, and we have a crossbite situation, and nature found a way to manipulate the natural teeth into a position that still work for that person. This person can still chew, this person can speak, this person can function without damage. Nature found a way. We may look at it just from a snapshot picture and say that's unattractive, but you have to keep in mind that this isn't framed in a face. This is just the picture on its own. You have to consider that this is a under 25-year-old woman who is beautiful, and this fits her and her features, and everything is golden proportioned. And so we look at it and say it's a misalignment or malocclusion, and Lady Gaga says, baby, you were born this way. So how do we rehabilitate this into a denture case? Well, let's explore that. Nature finds a way by moving the cusps around and finding places to fit them into a corresponding fossa. That's what nature does. Nature makes it work. So if you look at the molars, it's more of a situation that we like to see, a little bit more of a natural situation. Yet you look at the premolars or the bicuspids area, you'll see that now the buccal cusp is sitting in the fossa. What matters here is that there's a cusp and a fossa, whether it's a buccal cusp or a lingual cusp. All nature did was tip things and made it work, and so that you still can chew. What's important is that there's a cusp and a fossa. The upper cusp is what's going to hammer in and break apart the food within the lower fossa. So it's like a mortar and pestle type of approach. So again, we look at close-up photographs and we say, but when you look at it through an entire face and a person, it's framed differently. So you can see it's very tapered, but if you look at her occlusion, you won't see a lot of wear facets. You don't see a lot of damage. You don't see a lot of breakage. You don't see things worn out, which tells you that after 20 odd years of chewing, this works for this person. It's not damaging to this person because we don't see that damage. Everything is healthy and unworn down. We don't see those wear facets. So the system's functioning. So I take pause because these pictures show us, well, wait a minute, it's working in nature. So how do we make this work in a denture case? Whether we do this digitally or whether we do this traditionally, very similar characteristics and traits remain. Number one, we don't like crossbite typically because, again, we think it's unesthetic. And the denture teeth we're using typically aren't designed for it. There's only one product that I'm familiar with that was a specific designed crossbite tooth. Otherwise, we're taking it and we're crisscrossing them and we're making them work. So the lowers end up on the top and the top ends up on the bottom. We're not going to do that today. Crossbite considerations is that's not often taught. It's not a common occurrence. So we're left to figure it out on ourselves. So this is my goal today, is to, again, show you a new way, something a little bit different to help you. Normally we're grinding a lot and they're a lot of work. So I always want to circle back and say, well, what's your patient's normal? What does Lady Gaga say? Baby, you were born this way, and should you alter it? So the question now, that's a big question, because we have run into cases where the technician will say to me, well, Mark, the doctor just says don't set it in crossbite. But that's because they understand and have experienced it, that when we do set it in crossbite and we crisscross teeth and the bottom ends up on the top and the top ends up on the bottom, where it doesn't look good, it doesn't look aesthetic. And now we can use denture teeth that still are aesthetic and still will function in a crossbite, yet not make it look like a crossbite. And these are things that we can get away with now, and that we can achieve now, and we challenge ourselves now. So I'm going to ask you to let go and get out of your way. My wife tells me that all the time. Mark, get out of your way. You have to let go of what you think, and trust yourself to bend the rules and to push the limits. You have to keep in mind that much of what we have in our lives is because someone took an idea or pushed it and made things. We have telephones, we have cars, we have all these things in our life because somebody thought of an idea and took it and ran with it and pushed the limits of what was standardly done. That's what makes us better. So I want to talk to you a little bit about freedom and centric, because that plays into effect with what I'm going to teach you today of how to set teeth. Freedom and centric is, by definition, a flat area in the central fossa upon which opposing cusps contact, and permits a degree of freedom in eccentric movements, uninfluenced by tooth inclines. This is the kicker. That means is that when the tooth comes in, it doesn't hit and slide on the tooth inclines. We misdiagnose this. What happens is that the tooth will come into contact, slide into position, and it causes a problem. Freedom and centric is the ability to land in the middle here, and the tooth has, if you watch, it can wiggle side to side. Now this is showing a lingual cusp in the center of the fossa, and it works and balances like we typically do, but the lower is designed to permit a degree of freedom. So you have some wiggle room there. It wiggles. It moves side to side. We've missed this in denture teeth and in dentistry and in denture fabrication. Bear with me. Oh, I know I'm upside down. Wait a minute. Rotate image. Bump. It's not rotating. Hang on a minute. Okie dokie. We're not going to do that now. Okay. All right. Sorry, guys. For some reason, this is not rotating. Oh, there we go. There. Hey, I'm right side up. All right. So what we've missed is in dentistry that our natural teeth have a little bit of wiggle. So that's freedom. And freedom is our ability to move side to side in centric. And freedom is good. We forgot about this. So the cusp can lay into the fossa and it can wiggle a little bit side to side. That's freedom. You have that in your own teeth. So if you touch your teeth together in centric and you wiggle ever so gently, so don't go excursions, just go in centric. You should be able to wiggle slightly side to side. It's about a millimeter, millimeter and a half. It's not a lot of movement. And that's freedom. And we forgot about that. That's going to play into what I'm going to show you later. Okay. All right. Going to click back to the PowerPoint. I wanted to show you that freedom. And freedom is good. So that's what it looks like on denture teeth. So we are asking a denture patient, when they touch together in centric, we ask them to bullseye land centric every time, and that they can reproduce that every time, accurately every time. So we expect a patient. Do you know that that's impossible, correct? So we set this up on an articulator. We use denture teeth that are locked into position that have no freedom in centric. I want to be clear, there's only a handful of denture teeth in the world that have freedom and centric built into them. We forgot about this. And now we are asking a patient to land centric every time. I want you to think about the patient. We are asking a senior citizen, because most dentures are for seniors. Now, as we age, we lose effectiveness of our chewing system, muscles, neuromuscularly, to accurately land and pinpoint centric every time. So what happens is we're asking someone to land that centric. We set teeth in mind on an articulator like that it's perfect on the articulator, yet it goes into the mouth and it's a problem. Why? It's not possible for a denture patient to do this every time because there's no nerve into the denture or the denture teeth. With natural teeth, we have a nerve. We have a nerve that goes into that tooth and biofeedback to the central nervous system. Our brain knows where our teeth are three-dimensionally within our head. And there's biofeedback every time I touch, every time I swallow, giving biofeedback to the brain to say, hey, this is where the teeth are. A denture patient doesn't have that. So you have to appreciate it's like walking without feeling your feet. How do you know they're touching the ground? So now a denture patient can't feel their upper and lower teeth touch together. How do they know it's accurate? How do they know that it's reproducing accurately? How do they know? How do they know? Yet we expect them to. During the first part of my career, I'd ask a patient, touch your teeth together, please. Well, Mark, you idiot, they can't feel their teeth touch together. So how are they touching? Well, they're touching because, one, the muscles and muscle memory. So their brain does have a muscle memory of where the muscle and the masseter and temporalis muscles should close. So there's muscle memory there. The other thing that a patient learns is the pressure change. So you got to keep in mind, a denture sits on a ridge and it creates hydraulic pressure onto the ridge. So a patient knows that there's so much pressure induced when they touch together and swallow in centric. And then they learn that when they chew, there's so much pressure being induced onto the ridge. So then they know they're functioning like walking. There's more pressure induced. They learn to tell the difference. And that's how they figure it out. And that's how their central nervous system knows that their teeth are touching. So what happens is because it's not as accurate, we're expecting them to touch together. So I want to talk to you a little bit about the hit and slide. So what happens is when you don't find centric, you hit and slide into position. So if you look on the right side of the picture, you have the arrows and it hits and slides. The hit and slide is the problem for us. You need to have that freedom and centric because otherwise it rocks the denture, it hits and slide into position. The patient can't feel this happening. They only feel the result, which is the loose denture, sores that are induced by the denture-based rubbing because the bite's knocking in. If this is implant retained, then things are going to damage the temporomandibular joint, or the teeth are breaking, or they're coming back to you saying, I still can't eat. And they've now, even with a implant retained dentures, they're coming back and saying, it just doesn't seem to work. That's telling you that the teeth are not set into the chew cycle of the person. The chew cycle of the person contains the freedom and centric. So that's why I wanted to bring that to your attention. The other thing I want to bring up is that patients have a chew cycle. So this video talks about the chew cycle of patients. So as the video starts, patients are going to be given something to eat, and then you watch this. So watch the chew cycle. Does the mandible move straight up and down? No, it comes in at an angle. So now you have to imagine, look at the angle that it's coming in. It's like a teardrop. And the patient chews left and right. And now we're going to go through different chew cycles, different foods. So look at, it's not a straight up and down movement. So now you have to imagine the posterior teeth have to function within this chew cycle, within this teardrop, We have to set the teeth to function within this teardrop. If we get it wrong, there's going to be a hit and slide, and that's what causes the problems. Interesting, hey? Now you say, well, Mark, we checked for working and balancing on an articulator. An articulator is not mimicking this movement at all. This is a chew cycle. An articulator doesn't mimic that. It moves left and right at an angle, not like this. I want to show you these pictures because this is what I want you to remember when you set teeth. Whether you see a patient or you don't see a patient, this is how the system works. This is important. So what this does is this allows you now to try and remember that. Now watch the chew cycle. Here's my point. You see how this one's a little bit more vertical? It's a little bit more up and down, where the other ones have been a little bit more teardrop. Now, how to identify that? Well, you have to see the patient, you have to examine the patient, and you have to have the patient speak to you and try to function with you. If you don't, then you run into the hit and slide issue. So one of our biggest issues is that we're not setting teeth within the chew cycle. And this is what I found out and learned, well, through my OCD of why things were failing for me at the beginning part of my career and why I was having repetitive problems. And it was wearing me down. And I thought, geez, this is what I have to look forward to. I remember that. I opened my business and I've been open for a few years. And it was like, wow, this is what I have for another 30 years of my career. And I started to push it. And I started to ask myself why. And I had to get out of my way, you guys. And this is what I'm asking of you now. The hit and slide causes the problem. So what are regular contact points on a class 1? So I want to show you the red is the cusp on the upper that fits into the fossa of the bottom in black. The green dots are the cusps that hold the food in and have to be clear of the hit and slide during the chew cycle function. So the red dots are what takes and crushes the food. So it's the cusp. It sits into the fossa with the black dot. The fossa is the bowl that holds it. So this is a mortar and pestle approach. The green are the sides of the bowl where you don't want things to hit and slide. That's how this functions. That's how you crush food. Regular contact points on a class 3 are reversed because what happens is what nature does is they put the buccal cusp in instead of the lingual cusp, like normal in quotations. So we reverse it. What happens is now we have the buccal cusp sit into the black dot of the bowl, but there's still a cusp and a fossa, just like the previous pictures I showed you of the crossbite patient. The greens are reversed now. So now it's a reversal where you can see, whereas in a class 1 on the upper, it was the lingual cusp that was the going into the fossa. Now it's the buccal. Now the crossbite case, the lingual becomes where we have to watch for the hit and slide contacts. So it reverses itself. That's how nature found a way. Now I can use denture teeth, still maintain an upper denture tooth on an upper arch and a lower denture tooth on a lower arch. I still maintain that. All I've done is put in a different cusp into the fossa, and that's how you make it work. It maintains the aesthetics. It maintains function. All we've done is just move the cusps around. We don't now have to crisscross like we used to do with standard 20-degree denture teeth. So there's the comparison between crossbite contacts on the left and regular contacts on the right. So that's the comparison of it. So all we're doing is now putting the buccal in. So we have a standard setup. So the green dots are where you have to watch the hit and slide. The red dot is the upper cusp into the lower fossa, which is black. The other green dot is the lingual on the lower. So when this goes into a chew cycle and moves in a teardrop, it crushes the food. So the upper lingual cusp is crushing the food being held in the lower fossa. In a crossbite situation, remember we've reversed it. So now we've reversed our contacts. So now it's the buccal going in to the lower, still the fossa, But now we have a reversal of where we have to watch the hit and slide cusps. So they've reversed. But now that's how we do this, with now maintaining integrity, maintaining function within the chew cycle, and not having to swap out denture teeth like we did before with crisscross. And that's how we maintain aesthetics. You cannot do this with regular 20-degree denture teeth. It doesn't work. You have to do it with freedom and centric denture teeth. And that's VITA, lingo form, or MFT. The other denture teeth that are available on the market that have it, Ivoclar, and so this is where Jim closes his ears. Ivoclar has it, but only in Veneris. And Mertz Dental has it out of Germany, but only on their articular teeth. It's a very small group of denture teeth that have this freedom and centric principle, and the mortal and pestle. This is newer thinking, everyone. 20-degree denture teeth and every other manufacturer out there that produces a similar type of 10 or 20-degree or 22-degree denture teeth, that's all derived from theory and philosophy from the 50s. It's not 1950 anymore. And so now this theory is more modern and trending, where we have to start thinking of the chew cycle and how the teeth are operating within the chew cycle. So it's time to get with it and update. So the teeth are designed like a mortar and pestle. So VITA teeth are designed like that. And then all I'm doing is just changing out the cusp. And that's why it works. Most other denture teeth on the market are more of a milling. The 20-degree style is more of a milling style. So mortal and pestle is more efficient. So remember, we don't want to lock in the bite. We're going to put a driver or a cusp into the bowl. And remember, freedom is good. And it has to function within that environment. Remember that side shift, that freedom. Okay? And now we can turn things to suit it. So I'll show you that momentarily once we get into the hands-on portion. Remember, these stresses that were happening in our career that we face every day build up for us. And in 2019, the World Health Organization listed burnout as a disease. And burnout is real for us. It's repetitive problems with a patient that cause us stress, and we don't know why it's happening. It's because we were using denture teeth or a digital design that was locked together. Sure, the centric was right. Sure, it tapped in fine on an articulator, but it's not working when the patient chews. And it's not working when they have their chew cycle. Their chew cycle is unique to them, like a fingerprint or a retina scan. And we've done very little to modify the teeth to that and identify that. And that's my goal now, to introduce everyone to those things. So repetitive problems cause in stress. That stress builds up because you're not using denture teeth flexible to the needs of the patient. And that's where you get disillusioned with your career, you get burned out, you lose interest, you become lackadaisical, you get cynical about your career and your profession, because those things build up over time. When you start using freedom and centric denture teeth, you're going to see those adjustment rates drop. You're going to see the problem rates drop. I am living proof of this. I faced those things at the beginning part of my career, and now I have a much better control and handle on it because I'm doing it. And that's what I'm sharing with you. The type of teeth you use matters, and why I'm asking you to try VITA teeth, because it works and it's helping me and it's taking care of my stresses. These are your reps. Jim will bring these up later as well. So at this point of the presentation, you can pause it if you're watching this on YouTube after, or if you have a camera ready, you can, or your phone ready, you can snap a quick picture. But these are your reps in Canada and the US that can help you and support you, because we are all here to support you. So now I want to show you how this works on an articulator. So we're going to go back to the camera. So I'm going to take a moment to load everything up. Oops, I hit the wrong button. I hit print. Camera. All right. Yay. Hey, I'm right side up. Okay, awesome. Woot woot. We do not slap teeth together. We do not slap teeth together. None of us. What we do is complicated work. You are trying to set teeth inside a chewing system of a patient. So one of the things I wanted to show you on that video is that if you're going to stare at me for a moment and watch my jaw move while I'm speaking, it's going to give you an idea of the movement of my jaw and how the teeth function in it for me. So one of the things that we can do clinically is to say the days of the week and the months of the year in English and our mother language if we have one, because days of the week and months of the year contain all the phonetics of that language. So if I say Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, watch my jaw and the movement. We're trained clinically to look at the positions and the aesthetics. I want you to start to look at the function and the jaw movement. January, February, March, April, May, June, July, August, September, October, November, December. These are things that I want you to check for. Now in a mother language, if somebody speaks another language, Montag, Dienstag, Mittwoch, Donnerstag, Freitag, Samstag, Sonntag, the jaw moves slightly different because when they leave your office or the dental office, they're going to probably be speaking their mother language more. That was German, by the way. So these are things that you can either ask the doctor for, ask the video for, or if you're a direct care practitioner that you want to start checking the patient for. Okay, so I am going to rotate like that. I love it when things start finally working. All right. So remember, before this was the cusp, and it went into the fossa. And then that fossa wiggled. It had a little bit of wiggle room because remember, we can't ask a patient to accurately land in centric every time. So what was happening, we'll take the light off. What was happening is they would go through their chew cycle and they would hit and slide into position. But remember, there's no nerve to the denture teeth or to the restoration or the crown or the mill that you did on the implant case, and they can't feel it hit and slide into position. And that's where the hit and slide causes the problems. And that's why they come to you and say, it's not working, I can't chew. Because they don't know how to process that information. All they know is that it hits and slides into position. And they can't feel the hit and slide. So they know there's something wrong. They just can't equate that to you. And we misdiagnose it. So it's the hit and slide that causes the problem. And then we have to make sure. So what controls this is the fossa. So the lower is there to hold the food, bring it up to the top to get crushed. In a crossbite case, all we're doing is switching it over to this. So all you do is you switch over to now the buccal is in the lower fossa. That's all this is. And now the chew cycle operates this way. And this maintains the integrity of the aesthetics. This maintains the integrity of the chew system because this patient was chewing with natural teeth. It functioned this way. Remember, nature finds a way. And all it is just they stuck the buccal in. And that's what I want you to do. Don't be doing this anymore where you switch the thing around and put the lower on the top and the top on the bottom. No, not 1950s anymore, everyone. It's time now to change this. And all we're going to do is put the buccal in. And now that patient has a chew cycle. And all I have to make sure is that we've got clearance and freedom here as it goes through the chew cycle. And it doesn't hit and slide into position. We don't want the hit and slide into position. Okay, so I wanted to show you that on these teeth. So that's on these artificial teeth and my little demonstration teeth here. So whether it's in a normal class 1 or class 3, or excuse me, crossbite, that's what we do here. It's really as simple as that. Okay, all you do is just stick a different cusp in. What's nice is that gives us tremendous flexibility now to do that. I don't have to do every tooth like this. I can only do the teeth that are required in crossbite, that are necessary in crossbite. So whether it's just the molars or second molars, it doesn't matter. Whatever tooth is necessary in crossbite, all you do is just put the different cusp in. But you have to use teeth that are designed for that. And that's, in this case, the lingo form, or in the digital aspect, the Vigo. And the digital platform, because the digital platform from VITA is designed after the lingo form. And that's why they've done that. So it allows us that flexibility. Okay. So either Vionic or Vigo, from a digital perspective, you want to maintain that integrity. And that's how you maintain that integrity, because the teeth come either traditional or digital with the freedom and the wiggle. And that's what's important, is everything's got the wiggle, and freedom is, everyone good. All right. So imagine now you're sitting at your computer watching this, and now you've got your headphones on, and now I want you to say, freedom is good. And all of a sudden everyone looks at you because you just went good. All right. We've got to have some fun. Next. Teeth. So let's get right to the meat and potatoes of this. So this one, I might turn the light on. We'll see how we're doing for reflection. Okay, we have an upper. So this case is in crossbite. It is a crossbite case. And focus. So it is a crossbite setup case. Okay, so what I've done is I've set the lower posterior teeth. And what I did was I set that now for us to now just do some demonstration for the top. How I set the bottom is, this is where it allows us flexibility. So let me tip this to show you. So forgive me while I... Now, we have some options here. So from a perspective of a traditional setup, these teeth can be set on a 20-degree template. These teeth can be set on a flat template. These teeth can be set on a customized curve of Spear-Wilson. Okay, we have flexibility on them. So I'm kind of holding a ruler in there, but what you see a lot of Europeans and a lot of pictures from Germany come is they actually use a string. Now I've used a very large string, so it's typically a very thin, but when I do videos, it doesn't show up very well. So I've used a thicker white to just show the point of, they hold it and then they can move the cusp above or below the string. So a lot of Europeans are taught with the string, whereas here in North America, we're taught on a template. So we would just set the template down and the teeth can follow a template. So these are flexible because they allow you to set to a 20-degree, a flat, or a customized, according to whatever philosophies you want to follow or what's necessary for that patient and that situation. Nothing's wrong. The reason why we can get away with this and have different kinds of setups and different kinds of techniques on these teeth is because they're not locked together. They're not locked together. So remember that when you set the tooth, it has the cusp goes into the fossa, but then what that affords us is the ability to wiggle it into position. It wiggles, so it doesn't matter if it's off a little bit. So what we're going to do is we're going to set in the top and we're going to start. So thank you for your patience. We're doing this live. So I'm actually working. So it's not amazing. And I'm going to start in and around the molar area here to prove a point. and just start with our demo. Okay, so we've got the upper tooth. I'm going to put it into position, and I'm going to now pop that into position, and I'm going to slide that in. Okay. So what happens is the buccal rests into the center fossa of the lower. So what we're doing is instead of the lingual cusp going in, we put the buccal cusp into the center fossa of the lower, which is right there, the center fossa of the lower. Okay. Now what I'm going to do to highlight this is I'm going to color that cusp. So that's this one right here. So remember, we're doing the buccal. Okay. And that comes into and into position on the bottom. And then what we're looking for, and I appreciate I can see it, but I'm going to say it's getting hard to show up on the camera. We have little red dots right in here and little red dots right in here. So that means that the cusp is nestling itself right there. The one thing that I like to use are these pens. So those of you that follow me and have seen lectures before, I use a Stapler non-permanent, so you can also use a Sharpie non-permanent pen. Made in Germany. So you use a non-permanent pen, and I color the cusps. The reason being is I don't use articulating paper, because the articulating paper, even the thin stuff, is thick. And what it does is it bends between the cusps and it gives me a wrong reading. And I don't want a wrong reading, because typically where it gives me the wrong reading is on the guiding planes of the tooth. And then I'm getting an incorrect reading on the guiding plane of the tooth, and I don't want that. So that's why I use these pens. And I use them in the laboratory here in the lab. Clinically, you can't, because they're non-permanent. So what's going to happen is you're going to color the tooth, pop the denture into the patient, and the color will bleed. So I'll show you how to do that clinically, because I do not insert articulating paper into a patient's mouth anymore. So this is now where I'm going. And what I wanted to show you was now, and forgive me, I'm going to tilt this. Let me take the pin out of the way. Okay. There we go. It's having a hard time focusing. Bear with me. You can see the buccal cusp is nestling into the lingual fossa. And I appreciate that we're having a little bit of a difficulty. Camera's having a hard time focusing. Let's try a little bit. So that allows you the appreciation to see it. okay, that the buccal cusp is into the fossa. But what this does, though, is this maintains the emergence profile of the tooth, so aesthetically it looks okay. So this is the big deal now of not putting the bottom on the top and the top on the bottom, crisscrossing it like we would do with a regular, say, 20-degree tooth. What we're doing is we can maintain integrity and aesthetic integrity because of this, because the tooth has the emergence profile. It's still a top tooth. It still looks the way it should look. So aesthetically, it hides the crossbite. Aesthetically, it doesn't look weird on a patient. And aesthetically, a doctor or the dentist will accept it more, and ultimately, ergo, the patient will accept it because it's more of a natural based. That's why I wanted to share this with you, because it's more accepting to the patient. It's more aesthetically pleasing because all we've done is just put a different cusp in the fossa, yet maintaining the integrity, and it's going to function. The other thing that I wanted to show you now is typically we're going to unlock the articulator, and regardless of whatever articulator you use, whether it's a hinge, a Cavo, a Stratus, whatever type of articulator whip mix, we typically do this to check. So we take the articulator and we do this type of motion with it. So we lock it on this side and we do this motion to check for working and balancing occlusion. Now remember, I want you to think back to the video that I showed you of the patient chewing and working with it. They are not chewing like this. They don't chew like we check on the articulator. They chew in a pattern. Now you can see how I've taken my fingers and I've taught myself how to manipulate an articulator. Now I've tried this on hinge articulators, better known as clip clops. I've tried this on assorted articulators, and now I'm used to doing this. I do not do this anymore because that's not what's reflective in the mouth and how the system works. I want you to do this because that's how that tooth is going to function in a chew cycle. Now remember, some are a little bit more horizontal and flatter. Some chew cycles are a little bit more up and down. So if you can identify that, then good, because then you can check that in the articulator more. If you cannot, vis-a-vis because you're a technician and you don't see the patient and you can't get a video or any information from the doctor, then I want you to err on the side of caution and go more horizontal, meaning it's a flatter chew cycle. I'd rather have too much freedom than not enough. So what you're doing then is you are looking for contacts on the guiding planes, which are located here. So you're looking for the hit and slide positions and the hit and slide contacts. And you're looking for the hit and slide contacts on the lower arch as well in those areas. Now this holds true to a digital aspect. You doing this digitally or you doing this traditionally. In a digital aspect, all I'm doing on the digital scans and the scanning of the tooth is I have the ability to tip the tooth on the digital scans, and then I may have to do some manual adjustment after the case is finished in production, after it's milled or the base is printed and the teeth are glued in. Then I have to make those adjustments quickly, and I can. On a digital aspect, we have the ability to tip the tooth. Okay, remember from the factory, there is freedom for VITA product. So it allows us that freedom and that ability for wiggle. Okay, that's really important here. And then I have to think of this in a chew cycle. When you're a technician sitting on the bench, no one ever talked to me about a chew cycle. And I'm telling everyone, I spent a lot of time in my career banging my head on the wall going, why isn't this working? Till I realized that the articulator movement of a working and balancing of what I do is not reflective of somebody actually eating and chewing. And the only reason why I found that out and figured that out for myself is because I had a patient come to me one day and say, it's not working. I'm going to bring food to show you it doesn't work. And then they brought food and I watched them chew and I went, oh my gosh. And then that light came on for me because, again, I remounted the case back on the articulator and said, well, wait a minute, the articulator is not moving in the way that the patient was moving. How do I start to do that? And that's how I caught on to it. And I'm very thankful because that opened my eyes all those 20 years ago to where we're at now. You cannot use teeth that are locked together. You cannot use 20-degree teeth anymore. I'm sorry, it's not 1950s. It's time to get out of your way and think about this differently. It's a mortar and pestle and goes in, and then you have to figure out the chew cycle to make it work within the teardrop of the chew cycle. And that's how you make that work. Okay? 1 second, please. Lenore, can I have a blank piece of paper? So what's really important is to start to identify that. That's been a game changer for me. Thanks, Lenore. Everyone say hi to Lenore.
Hi.
But you can't see you. Okay, so I'm gonna flip back. Okay, so remember, we have a chew cycle of a patient. So remember, it's some kind of a chew cycle, flatter or more vertical. And now we have to make sure that those denture teeth, regardless if they're in crossbite or not, also function within that chew cycle so you don't get the hit and slide so it slides into position. No one ever taught me that. I figured that out on my own of what I was missing. And now that I've learned to modify and identify, boy, my stress has gotten a lot better. It's gone down a lot, and I'm not inundated with adjustments afterwards. If you have a denture tooth, even if it's in crossbite, sorry, I'm a terrible artist. Okay. Again, I have to watch that chew cycle. Now it's flatter, so I know this needs more room. So I can automatically go in and start watching and grinding here. I'll use red so you can see it better. Right in here, these areas, so that it functions and doesn't hit and slide, because the patient cannot feel it. They cannot tell you. So what are we seeing? We're seeing now a movement of the digital bite scanning. So there's devices that I can put into a patient's mouth that are digitally tracking how the patient's biting together. And what that's doing is it's also showing us the hit and slide contacts. I'm just teaching this to you manually right now. And so we have to pay attention to that. So number one, use teeth that have freedom and centric and can wiggle and can move. Then you need to set them so they function within a chew cycle. Whether you see the patient or not, that chew cycle exists. You have to think about it and think, what kind of chew cycle is it? Well, you can make some educated deductions. As a technician, if I know that I have a copy of the old denture and it's really worn flat, then you know that their chew cycle is going to be flatter. So now I can set the teeth with a flatter cycle in mind, watch the guiding planes, and it'll work effectively. If you have a case right now that's driving you nuts, and everybody has one of those in their office, don't you? You're thinking, yeah, chew cycle. Again, I love this. Mark, my bite's right. Mark, my bite's right. Of course, you guys, it's quite simple to find centric. I spend, again, I'm going to be controversial. I spend much less time now in my career worrying about centric, because how does that patient find that accurately each and every time? They can't. I have to give them that flexibility and wiggle room, which is why I'm not as worried about centric anymore. I'm more worried about how the function is, because they can't tell me it hit and slides. And now with implants and bar retained dentures and these things now that we take the denture off the ridge and now they can't even feel it compress. We've taken away the hydraulics. How do they tell that their teeth are together? It's 100% muscle memory now. You're relying on these things to be accurate each and every time. Not a safe bet, because these things are anything but accurate each and every time, meaning the muscle structures. And so now we have to add that centric in, that freedom, and then watch the chew cycle, digitally or traditionally. You have to allow for it. That means you got to use manufacturer's teeth that incorporate it in. And let me tell you, it's a really small list. So you have to pick and choose, because what's going to happen is the case is coming back to you anyway. It's coming back on the adjustments. It's coming back with the work orders that say we have another problem again. That costs everyone time, money, the patient's aggravated as well, and it's expensive and it's stressful, and that builds over time in your career and you become burned out. I'm worried about you and your career right now. Whoever's watching this, I'm worried about your career built over time. I saw with myself, you just start to get disillusioned with everything. This is about saving yourself, your stresses, and then your patients, because it's going to function better and we're not inundated with adjustments because things work better. So we're going to set another tooth. So let's set, what do you think? We set a bicuspid? Yeah, Mark, that's a good idea. Let's set a bicuspid or a second molar. Yeah, okay. All right, let's set one of those. Okay, I'm gonna ask Jim a question while I'm sitting here out of focus. There we go. Jim, are you there?
Yes, I am.
Hi. Okay, do we have any questions pop up yet?
We do have a few. You went over group function, or you went over the setup for a class 3. Do you set them up as a group function, canine guidance? What's the best for a class 3 or end-to-end situation?
Oh, class 3 end-to-end. Yeah, okay. So on a denture perspective, I'm still going to set them in group functions. So there's still a working and balancing element in this, but I set to the chew cycle, which means I manipulate that articulator. Okay. So now, so again, whoops. You know, I have to say it's quite challenging holding an articulator with teeth in wax and try to get it to work all at the same time. Oprah calls this
need a third hand, huh?
Well, what we need is to get back to, you know, in-person courses. Wouldn't that be nice? So again, I'm just lining up the cusp into the fossa, and now it's a buccal cusp. So to answer the question, do I go group or do I go canine? Well, it depends on what I think I can get away with on that patient. And it depends on what I think. Now, bear with me. So I'm going to just slide away and I'm going to jump to a different PowerPoint to show you this. So bear with me, everybody. Whoops. No, I don't want to leave the webinar. Okay. I'm jumping to a different PowerPoint to help answer that question. And I want you to take a look at this, everyone. So you asked me, what do I do? Okay. I want you to look at this patient and when they speak. Now I put the arrows on there to show you. Look at her jaw move. Do you think a regular setup works for her? So I set, look how I set this. I set this case with about 5 millimeters of overbite. Oh my gosh, Mark, that's not supposed to work. I'd fail school if I did that. Yet that's functioning in the mouth right now. What I did was I gave her freedom. I gave her the ability to move out to that side with this tremendous amount of overbite, which shouldn't work because the denture should dislodge. This is an upper and lower denture, non-implant retained. She does not wear adhesive. Why does this work? Because I worked within her chew cycle, her function limits. I identified it. I used VITA teeth. I've got wiggle room in here. I have freedom in centric, and I followed and set the teeth so that I've got more displacement on as she postures to her left, which is now the visual picture of the right here. And that's what makes this work. This is about challenging yourself and challenging what you believe. And this is about getting out of your way. Jim, next question. Let's answer one.
All right, we have in the video of the patient chewing the gum. Is that a special gum, non-stick gum that was used?
Yes.
Do you know?
Yeah. That's a video out of actually out of France, but they were using they were using gum. Yes, and I tried that. So I've actually had the patient. Chew apples, cucumber, green pepper, and then non-stick gum. So I've tried those different things, and it's been effective because some people don't like cucumber, but I'm trying to think of something just soft. So I'll identify it with that, or remember days of the week, months of the year, but not looking at the aesthetical value of what days of the week and months of the year provide. I'm looking at the functional value of the jaw posturing days of the week, months of the year. And then I'm setting the teeth within that limit. And I've done that digitally and I've done that traditionally, and it's working because we're able to modify things according to that. So again, it's the same idea here. All I've done is I've just stuck the buccal cusp into the corresponding lower fossa. And then now I'm just going to follow a chew cycle of the patient to make sure that I don't have interference. Now, granted, digitally it is a little harder because digitally I can't manipulate an articulator, but I understand it's there, and then I can tip or alter the tooth slightly digitally, but then I might have to come back manually after it's completed and do some spot checks and some spot adjustments. That's fine. But you have to keep in mind of does it work? Yes, it does. It's effective. Okay, another question, Jim? Because we'll bang some of these.
Yeah, so to eliminate the hit and slide, do you reduce the lower or upper cusp?
Lower. Always on the lower.
Okay.
Yeah. So again, so the camera's so close I can barely get the pen in. Okay, so it's always on the guiding planes here. Okay. So it's on the, so that's where I go first. So the guiding planes, typically I'll see the strike on the bottom on the guiding planes. Now you have to watch because now in a crossbite situation, because I'm using the buccal, it's a thinner cusp than the lingual. So what we typically see in a crossbite situation is I'm gonna get strikes here because the cusp is so big, and I'm gonna get it on this guide plane because this is such a big cusp. So I'll see a lot of strikes there. And then what happens is when I color it with the pen and then I go through the movement, you'll see this mark come across. And you can see there's just that very slight little line. That's why I love these pens, because then it tells me that it's hitting against this, for example, this here, and then I can just adjust that specific line away. And that's why I love using this type of system with the pens, because it's very, very accurate. And that's what I want. Awesome. Does that answer the, Jim, do you think that answers the question? So typically it's the bowl,
Yeah,
the
it does.
fossa. Yeah, it's the
Thank you.
fossa. But then I always just go to the top to also make sure it's not hitting on any of the guiding planes here, just in case. Okay, you're going to see it on a crossbite because again, I've used a different cusp. But on a standard class 1, typically, again, just depending on how flat or robust the chew cycle is, I might get some on the buccal upper here, on these cusps here. Okay, so it's a rethink of how the system works. It's a rethink of how we approach it, where I'm again not relying, say, on the articulator. And everyone, I'm not so much worried about centric occlusion anymore. So don't take me out to the woodshed and beat me, because I'm not. I'm more worried about how this thing works. We spend so much time worrying about centric. You guys, it doesn't function in centric. You don't eat in centric, do you? The patient comes in and says, yeah, Mark, I can't eat. It doesn't work. Okay, bite together. They find centric, no problem. It's not functioning because it's not functioning because it doesn't function in centric, everyone. So start to let go. Challenge yourself. Now, how do you check this in the mouth? So we'll take a break from questions. So what I do is I take a Q-tip or a cotton swab. I shouldn't use brand names. And I use a petroleum jelly product and I coat it. And then I come to my articulating paper. So I do this clinically. So this is how I check this intraorally in the mouth. So I'll take the denture out and I dry it off. And then I've taken my cotton swab, put petroleum jelly on it, and now transferred the ink over. And then I go in and I mark and color up the teeth. So I'm more interested in the cusps. So forgive me for shaking. And then that'll go in the mouth. And then I will have the patient function, talk, okay? Pretend to chew. Maybe even have just 1 or 2 chews of gum on the other side. Okay, because if you put gum on this side, so I'll check this side with the gum to have them chew on it. But then this side will function. And then I open up and I'm looking. So look, see, look at that. There's the hit. See now? So there's a little red mark right there. And I appreciate, sorry, there's only so much we can do with a camera. Look at that. So that's hitting right there. See, it got marked away. So that's how I would check that in the mouth if I need to. So it's, again, I don't put articulating paper in the mouth. Why? The minute I introduce articulating paper, regardless of its size, what's the first thing the tongue's going to do? Touch it and recoil backwards, and the tongue retrudes. Your bite's wrong. You're not going to get function at all now because the tongue isn't in a normal position of what normally happens for that person. So this alters it and alters the tongue position, which is why I never use articulating paper. Now you say, but Mark, why don't you use just a quadrant and you use the forceps or something to hold it in there, just this. But then I've had to stick it in their mouth, pull their cheek and say function. So I'd like you to try that. Stick your finger in your mouth and try to talk. Or if you have access to a forceps or something, put that in, push your cheek out and try to function normally. You've introduced something and now you're pushing on the cheek. So the biofeedback's going to the brain, to the central nervous system going, well, wait a minute, something's pushing against this. How do you know this is accurate? Get your hands off the patient. You need them to give you the information uninfluenced. That's how you do this. Get your hands off of them. So from this position, you can see how now I'm developing where all I've done is just put in the buccal. cusps into the lower fossa. And now we'll finish off just with the first premolar to show you we have a little bit of flexibility. How are we doing with the questions, Jim?
Fine. We're caught up. So go ahead and proceed.
Well, nice. Thank you. So the first premolar is an interesting situation. So we have a little bit of flexibility. Depending on where the crossbite starts, I can either set this in a normal class 1 position where the buccal overhangs and it's the lingual cusp sitting in. And that's how you typically see crossbite, because crossbite usually only shows itself in and around the second premolar or the second bicuspid area for most situations. So we can have a normal quote unquote class 1 position here, which maintains the integrity of the aesthetics. Because remember, when the patient smiles, you really are only showing to just posterior of the first premolar or first bicuspid anyway. So that's what maintains the integrity of the crossbite. If I have to, I can set that into crossbite immediately as well. Yes, it's a little bit more noticeable, but it still maintains because we still have an upper on the upper and not a lower on the upper because we haven't crisscrossed it. Now, if I can do a normal setup relationship for the first premolar, and I can do that, then what you see when I open up the articulator is we typically then have a step here and there's a little bit of a gap because this tooth is out more buccally, this is more in lingually. So what we can do to counteract that is because the teeth are not locked together, because I have a cusp in a fossa, so it's not a locked in occlusion, I can actually take this second premolar once I warm the wax appropriately. And I can turn it. See how I'm turning it? And then what that does is that brings out this facial aspect of the tooth. And now that lets me hide it a little more to have a little bit of a better blend. Yet what happens is I still am maintaining integrity of the cusp. So remember, it's crossbite. So right now we have this for a normal, and now it switches over, but I've turned the tooth. And all I've done is turned the cusp within the fossa, but I've changed the facial aspect of the tooth, but I can turn it because it's not locked in. I have freedom, and it lets me turn things. So I can either have the thumb side more present or my pinky finger more present, whatever I need to do from the facial aspect of the tooth. That's the beauty of freedom in centric denture teeth. And you can change that digitally as well, and we can modify that digitally where you can identify the tooth. And that's what works really well here with Bionic Vigo, because they're individual teeth. And so then I can tweak things to now maintain that, yet maintain the integrity of the setup and how it functions in the crossbite mode. Okay, so that's what we could do there for that. So what I wanted to show you on crossbite was we're putting a cusp in a fossa. So typically we see a lingual cusp. In crossbite, we're going to put a buccal cusp into the fossa of the lower. And then if I need to, I can twist and turn things to make it work. And you can do that traditionally or digitally, just so that I've exposed this facial aspect to just help if that patient smiles a little more and you see a little more back there, then I've exposed that. And I've exposed that facial aspect here to just help hide that step so it blends a little more. You cannot do that on 20-degree teeth or any other teeth other than freedom and centric denture teeth. So this allows me to calibrate more to the patient, hide things more for the patient, and still deliver them a product that they can chew with and function with. Okay, Jim, any other questions that popped up?
No, none at all. I think we're really good.
Yes. Well,
You explained yourself very well.
Why, thank you. If you have a question, let me know, because we're in the thick of it right now, everybody. And actually, we're doing really good on time, so we're going to finish early. So look at that. You actually will have lunch time today. Before you got to go back and deal with all your cases. The last thing I want to talk about, and I'm gonna switch out and pop this back in, and then I'm going to so I've segmented everything to make this kind of work for video type of presentation. Okay, so we've popped anterior teeth in. And so the question lies with how much overbite and overjet do I do? Now, typically on a prognathic case, you're not gonna have a lot of overbite and overjet. So typically you're going to see a little bit more end-to-end contact. Typically because the lower jaw is larger, so it doesn't move as much. So remember when I had them speak days of the week, months of the year, it doesn't move posture forward as much because the jaw is just larger than the upper. So you don't see a lot of range of motion. So typically we'll see more of an end-to-end contact. Now, what I showed you in that other case for that one lady was I had a tremendous amount of overbite that, of course, when I moved the articulator, the teeth were hitting and contacting, but they didn't in her mouth because I set this to her chew cycle and it worked within her chew cycle. And so it's really interesting, everyone, that you have to let go of what you think. And that's hard for us because I'm asking you to challenge yourself. So typically, people ask me, well, Mark, how much overbite and overjet? So if you're typing that in, just wait. How much overbite and overjet do you use? I do not set 1-to-1 or 2-to-2. That's standard. 1-to-1, 2-to-2 is what we see in industry. Well, how do you know it's 1-to-1 or 2-to-2 in my mouth or in your patient's mouth? How do you know? You don't, unless you look. And again, you have to look and see again, how the jaw moves, how it postures through chewing, through watching the patient chew, or a video of the patient speaking. And we can now watch that to see whether or not I need 1-to-1 or 2-to-2. Now, in the mouth, if you get a lot of chipping and the case is coming back and it's chipped a few times, especially on an implant case, remember, the patient can't feel. The patient can't feel the teeth hit. They can't feel the teeth contact. So they can't tell you there's a problem, especially if that denture is on a bar and it's off the gum, because now they've lost all sensation of the denture on the ridge itself and the compression and the hydraulics. So now that happens where the teeth are chipping and it's frustrating. So then I say, well, remember, okay, I'd rather the teeth break than the bar breaks. I'd rather the teeth break than the temporomandibular joint gets damaged. Because remember, you have a responsibility to protect that temporomandibular joint. You have a responsibility to protect that joint. And when there's a problem with this, it doesn't show itself right away. So if I'm an implant patient and I've got all on 4s, top and bottom, or say all on 6, and I touch my teeth together, I can't feel them touch together. So remember, it's muscle memory that's causing this. The denture sits on a bar. I have no idea of compression or hydraulics. So the only way I know my teeth are touching together is if I physically look at myself doing it, or I touch and my muscles can't close anymore. So now how accurate is that? Well, these muscles, as I said, aren't that tremendously accurate. So if there's a hit and slide, what's going to happen is that joint's always moving a little bit because there's a hit and slide. Yet what's going to happen is it's going to pull, and I start to get ringing in my ears. But I don't equate ringing in my ears to my bite's off, because I can't tell, because I can't feel it. When your bite's off naturally with real teeth, if your bite's off, you can tell. And prolonged time, the tooth moves, and then all of a sudden, because it's moving and getting pushed on, the tooth gets sore. So then I can go to my dentist and say, something's wrong. It hurts. It's sensitive. It's painful. So then the biofeedback is there to say there's a problem with the occlusion on that tooth. On an implant case on a bar, they can't feel any of that. So what happens is now you're starting to get ringing in your ears. That can turn to tinnitus, which is now long-term ringing. Or you can get vertigo or equilibrium problems. Yet we don't equate it to my bite's off. And by the time someone diagnoses that, it's really too late. It's gone too far. So we have to really watch when that happens. So how do you check that now clinically? So I can check that clinically. Same thing, Q-tip. And even if this is an implant case, so we'll pretend it's an implant case. I dry the denture off in the mouth, even with the chipped tooth, whatnot, and I color the lower anteriors, and then I have the patient talk and function. And you have them talk and function and speak. And then what'll happen is you'll see the mark come up here, and you'll see the problem. And then you can adjust, because the teeth are in the wrong position for their chew cycle. So again, you have to set all of the teeth within that chew cycle, even the anterior teeth, because remember, I have a chew cycle that looks this way, but the chew cycle also follows, here's the upper, here's the lower tooth. There's also a chew cycle that functions for this case. But remember, because it postures forward, so there's also the three-dimensional chew cycle that goes this way. So we've got different cycles involved. And if you're finding it's chipping here, that tells you that it's in the wrong position and that you need to reposition it, because it's not syncing with that posturing or that chew cycle of that person. So we chatted now about crossbite, about putting a cusp in a fossa. We've talked about now how to turn things and move things to that fossa. We've talked about now the aesthetical value of maintaining an upper on an upper. We've talked about now the value of freedom and centric denture teeth and why I use this product and why I use VITA and Lingoform and now Vigo digitally, because now I can take that information and I know that there's wiggle room in the case. I know that it works well, either traditionally or in a digital aspect. And then I can modify. And after digitally, I can still gently touch the teeth and modify them. These are acrylic glass teeth. So they're acrylic glass from a digital perspective, or they're acrylic glass traditionally. And then I don't have to polish acrylic glass because it self-polishes. So it's really awesome. I don't have to. I just use a very fine burr, a diamond or such that's very, very fine. And I just gently adjust the occlusion as required. And you don't have to polish it after because it self-polishes. So the one thing that I want to leave you with, so bear with me as I circle out of this, and I want to show you this. So I'm back to my PowerPoint here. So because we're talking crossbite, let me just bring this up, because now this is from a digital aspect. So we did this digitally. So my thanks to Jason Atwood from Core 3D Centers in Calgary. He's my superhero. When we do this, we did this a very similar case where it's a class 3, and we had to take things, and you can see here even where to make things work digitally, we actually had to, if you look at the upper teeth, we actually had to drop You can see here we've had to drop one of the teeth. So we have a full complement of teeth on the bottom, yet we dropped the second molar on the top. And then look, we've actually have the cuspid resting into a fossa. So long as you have a cusp in a fossa, you can make things work. And this case worked digitally. And what's nice is you can see that we can do a cross section. So I can see, I don't think I have the full picture on this one. So we dropped the second molar on the upper because it's class 3. We were able to shove everything forward. So we really pushed the limits of the software on this, and we did a 3-dimensional denture, and we did a digital denture for this person, and it was pretty cool because it's a very unique case, one of a kind. And what the cross sections do here is it shows us. You can see that on the right hand side, we're looking at the buccal cusp. Now it's in crossbite into the lower fossa. And so we have those cross sections to show us what's happening 2-dimensionally. So that's cool, right? And then we can see we're end to end. And what I did on this guy was I thought, let's try this. So I inserted the upper and lower digital dentures. And I didn't use any pressure paste. I just put the dentures in his mouth and I gave him a piece of apple because I thought, let's test this. Because I know that I've got freedom in centric because it's Vigo, so I know the freedom's there. I know that this is acrylic glass teeth. And I said, okay, here's an apple. So he's in crossbite. We've taken the molar off the upper. We have different cusps sitting in different fossas. And I said, here's an apple. So you keep this in mind. Inserted, gave him the apple. And now he's chewing an apple on a brand new inserted denture. And Jason, I've never showed you this because I think Jason's watching. Look what we did. And he's honestly, the thing hasn't even settled in his mouth yet. It's been in his mouth for a minute, and I gave him a piece of apple. And the thing isn't whacking all over the place and running around. And then again, when he bites into centric, look how it's off. Look how the centric's off. I don't care because I know I have freedom in centric. I'm not worried about him reproducing centric every time because he doesn't have to, because I gave him a product that doesn't have to. So this is a bilateral crossbite prognathic case that I've just showed you traditionally that we did digitally. Isn't that cool? Now we had to move things around digitally. But the fact is that we have a lower fossa, we have a cusp, some buccal cusp of some shape or form nestled in there. Heck, on his right hand side, it happens to be an upper cuspid that sets in there in centric. It doesn't matter. It's a cusp and a fossa, and that's what helps him eat, and that's what helps him chew and maintain a quality of life. And we were able to do that even digitally, following the principles of what I just showed you. And that's what the brilliance is of this, is we're able to do that. So Jim, do we have any other questions that have popped up?
No, I think that's it. We answered all of them earlier in the webinar, so that's great. So are you?
This is about setting teeth. Can you see me first off?
Yes.
Awesome. This is about setting teeth within the functional limit. And again, I wanted to show you the crossbite to now show you, okay, all you do is just put a buckle in. But again, don't do that with 20-degree teeth. It's not going to work because they're not designed for that. You have to use a mortal and pestle tooth, which is lingoform or Vigo or MFT. You have to have that ability to do it. But look what it can do for you. And then from a digital aspect, that's what we did, was we really pushed the limits of the software and made it work, and it works for that person. And then again, it's functional for that person because it's mortar and pestle. And we tried to set the teeth within the chew cycle. And that's what I wanted to impart with you today, everyone, is that ability. don't so much worry about the articulator movement. I want you to think now of that chew cycle and moving an articulator to mimic that chew cycle. And whether you see a patient or not, that chew cycle exists. Whether you're, as a technician, told of the chew cycle or not, it exists. It's there. And so now you're aware of it, and you have to think of it. If you're given no information at all, be conservative and say, okay, I'm going to mimic that it's a little flatter, because in most cases it's going to be flatter. So mimic that chew cycle so it's a little flatter. The adjustment rates are going to go down. The patient acceptance rate is going to go up. I taught you today how to do this manually instead of having to spend $8,000 to $10,000 on a electronic bite calibration system. I'm showing you how to do that traditionally or mechanically by just looking at a person and setting teeth more. And that's what I wanted to impart with you today, because that's been a big deal. Jim.
All right, thank you, Mark. Greatly appreciate it. Let me bring up something additionally, and we'll tie this off.
And hopefully everyone gets to eat lunch today. Please take 5 minutes for yourself. Remember, don't burn out. And I appreciate you can't do it every day, but you have to try, okay? Burnout is big in our industry. Okay, the more denturists I talk to, the more technicians I talk to, it's real. And this is something I wanted to practically show you to try and help reduce your burnout. And that's what I wanted to share with you. This stuff works.
Yes, it certainly does, and I appreciate it, Mark, for demonstrating and showing and going over all the aspects of Class 3 end-to-end type bite situations. I know that the audience is really, pleased of having that information now so they can actually use it in everyday cases, so greatly appreciate it. One of the aspects, if you're asking, is CE for this webinar. You can obtain your CE. Just you will receive an email from our education or marketing department. Just respond to that. The workshop has been recorded, so you can go revisit Mark anytime you'd like, and along with other webinars that Mark has already recorded for us. And then those are posted on our YouTube channel, our social media channels, and so forth. YouTube, VITA North America, LinkedIn, Instagram, Facebook. You can find links in all of those for this. You can also reach us here at the Technical Support Department here in VITA down in California. This is some information for there. Please feel free to give us a call, ask away. We have local reps, most likely in your area, so feel free to give them a call as well if you have any questions about costs and things of that nature. And then, of course, we have additional webinars coming down the calendar. So please join us again later this year. Mark's got several webinars still scheduled, different topics, and we will continue those throughout the year as well. So this is Mark's information. If Mark's been gracious enough to allow, technicians, insurers, dentists, who are watching this video, this webinar today, to be able to give them a call and say hi, and then also just to ask away some questions.
We're here to support you, please. I can't promise I'll respond to you within 5 minutes, but give me a date. However, we'll get back to you, and I'll get back to you. We're here to support you. And this is about, again, being a superhero for a patient, whether you see the patient or not.
All right. Any last words, Mark, as we wrap this up?
Just thanks, everyone, for your time, and I really appreciate it. Thanks for investing in yourself. We're here to support you. Please contact us if you need us. You can also follow me on Facebook and social media. So I have an Instagram and Facebook page and LinkedIn, and I post some pictures and stuff like that on there as well. Again, we're here to support as a group, and I'm thankful to VITA North America and their support of my messaging. So thank you as well to VITA and to Jim. And remember, you don't slap teeth together. You don't. What we do is technical. woot, woot. And it's important. And at the end of the day, there's a patient attached to that thing. And please don't forget it. I appreciate we get busy, and I appreciate there's demands on our time. And this is about, again, just holistically remembering some of the small points and our takeaways. Chew cycle, and that you have to set the teeth to function within that chew cycle. Remember freedom, and the wiggle room and freedom is good. Remember those things, and as you sit and design or traditionally wax knife your way through a case, remember those things are there.
All right. Thank you very much, Mark. Appreciate your time and your effort to
Appreciate
educate
everybody.
all of us. So
Nice.
those of you, again, you can join us on our VITA YouTube to watch Mark again. Otherwise, this concludes today's VITA Learning webinar. Thank you for joining us today.
Bye, everybody.